Thank you. And you've seen already my conflict of interest today. Now, when we look at heart failure with preserved ejection fraction, we need to see, first of all, and that is important, sign and symptoms, then the left ventricular function, and the objective evidence of cardiac or structural functional abnormalities, including, and that can include the natriuretic peptides. So that tells you one important point is that basically you can have you can use either the echo or the natriuretic peptides, providing that you have signs and symptoms. And that is a very important point that we need to stress, because it will simplify the diagnosis. Also because the diagnosis, can be very simple, and the majority of our patients have this dilated atria or thickened left ventricle or EA ratio. But what is important again and again is to try to use whatever you have in order to maximize and not delay the diagnosis. There are some countries in Europe where, for example, if a GP asks for an echocardiogram, it may take 6 months or 4 months. So because it's a socialized care, and that may affect the diagnosis, whilst if you use the NT-proBNP, that can be a way of simplifying and reducing the weight. The other point is what I mentioned this morning. We don't have to look at the silus, but there is overlap always between PEF and REF. And I believe most of you receive the report from the Echo Lab saying left ventricular function 45–50%. So what is that? Is mid-range? Is HFpEF? It's we don't know, and it is very, very difficult that we always get a very precise measurement. And also, even if we receive it, there is an error in measurement that is between 5 and 10%. And therefore, there is a big overlap between the different diagnoses. So we need to talk more about trajectories. So patients that start, let's say, 45% and then become 50%. So what are they? Are they mid-range or they're preserved? Those, again, that have an atrial fibrillation fast, they've controlled, then they go back and to 50%. What are they? Mid-range or they are preserved? Or those patients instead that start at 45 and then that is a progressive decline of left ventricular function. These are patients that progressively decline. We don't have to wait to get them up down to 35%. Then we have those who invariably stay there, 45% forever. And for example, those with left bundle branch block and no major symptoms. And then we have those who improve. Then we start at 35%. We have seen the previous cases of patients that with optimal medical therapy, they do better and they are improved. So when we look at patients with left ventricular function, I would put together the 40 and 40 to 50 and 50 to 60. So, and especially those who tend to improve when you give therapy, then we have different possible scenarios. We have patients with normal left ventricle, patients with concentric remodeling, other with concentric hypertrophy, other with eccentric hypertrophy. So do we have common mechanisms? No. There are different mechanisms that are underlying the different causes of heart failure, ranging from renal dysfunction to diabetes, hypertension, coronary artery disease, COPD. Different mechanisms in most of them, altered relaxation as a consequence of stiffening, altered diastolic function as a consequence of altered metabolism, and therefore we have different target comorbidities. Now, when we looked at the data on the different types of REF and PEF, then you can see that different risk factors tend to be different between men and women, between patients of different age, different phenotypes. And therefore, you can see that the ischemic phenotype tends to be more frequent in men and with reduced ejection fraction in like CKD, whilst in patients with more PEF, they tend to be women, hypertensive, diabetics. Now, and that reflects what we see in clinical trials. I mean, these are the clinical trials conducted in PEF. As you can see, the majority of patients were hypertensive. For nearly 50% were diabetics. So diabetes and hypertension are a very important feature of patients with preserved ejection fraction. And we looked with Gianluigi Savarese at the patient characteristics in the SWEDE-HF registry, and when trying to differentiate the REF from PEF, and we can see that again, the hypertension was more prevalent in those patients with PEF, and diabetes was slightly more prevalent in patients with PEF. Atrial fibrillation instead was very prevalent in patients with preserved ejection fraction. Then they tried to identify those patients with different phenotypes, and they tried to see whether phenotypes may progress differently. And you can see that there are different clusters. So this cluster, the young, the less comorbid, with more devices that tend to have a better prognosis, whilst those with the phenotype 4 and 5, so those obesity, hypertension, diabetes, or those with older ischemic heart disease, diabetes, and hypertension, they are those who tend to do much worse. Look at the event rate. Right? The event rate was around 50% at 2 years, so it's very high. So it is clear that within the heart failure with preserved ejection fraction, we have different phenotypes. They behave differently, and again, these data are those data have been mirrored by data on the other side of the Atlantic, where you can see that those patients who are women with advanced age, with lower BMI, high rate of atrial fibrillation, are those who tend to do much worse. And similarly, those patients with obesity, hyperlipidemia, anemia, and are also those who follows. Whilst the younger and those with one single risk factor tend to do better. So we can put all this data together and then group 3 different phenotypes, mean phenotypes. And there is a first one of the young patients with normal left ventricular function, less stiffness, and they may have lower natriuretic peptide levels. They tend to be much better. They tend to do much better. Those with obesity, diabetes, inflammation, hypertension tend to do much worse. So the main message is that women hypertensive diabetics are those who tend to be to do much worse when they are diagnosed with heart failure with preserved ejection fraction. And again, other data from other studies, always looking at this phenotype heat map. So looking at where are patients who do worse, they always identify these older patients with cardiac metabolism, with altered cardiac metabolism, and they tend to do much worse. Now, with the HFA, we put together this position paper where we have identified patients with different comorbidities, and we gave different weights to the different comorbidities. And this is important because comorbidities then need to be used to drive our therapy in patients with heart failure. We know that we have to use the SGLT2 inhibitors in everyone, but also we need to we know that we have to use appropriate treatment for the different comorbidities. And often treating a comorbidity with a drug that is not cardiac friendly may worsen their condition. And it's for this reason that then we came out with an algorithm for treatment of patients with heart failure and preserved ejection fraction. So I would say with patients with left ventricular function greater than 40, where first and foremost you have to use diuretics, and if there's congestion, and dapagliflozin or empagliflozin. Once you've started that, then you look at the comorbidities. So you focus mostly on those who are more important. So arterial hypertension, type 2 diabetes, atrial fibrillation, obesity, COPD, and iron deficiency. And then you look at those drugs that have been proven to be effective or safe for that specific comorbidity. For example, for arterial hypertension, there is a compelling evidence for the use of indapamide. In the Harvard study, reduced heart failure hospitalizations by 65%. Nebivolol as a beta blocker, as is the only one that has been proven in the senior study to be effective in higher left ventricular function group, and then the MRAs, because they're very effective in hypertension. For obesity, we have heard about the data, and we'll listen today the data of semaglutide. Tirzepatide is also very efficient and it's safe, so it can be used. In COPD, what is important? There's one very important lesson. Never refer to respiratory physicians. Referral to respiratory increases mortality in heart failure. That has been proven in 2 different studies. And main reason is that they stop beta blockers. And, but also we have evidence that LAMA-LABA combination, they're effective and reduce events. And even the triple combination is effective. Then in ischemic heart disease, we should give a priority to those drugs who have a metabolic effect. There are new data coming from ranolazine and trimetazidine showing efficacy on relaxation, but they are safe. And for type 2 diabetes, we've heard the importance of GLP-1 receptor agonists on top of the dapagliflozin and empagliflozin. And if CKD is present, also the finerenone. So we know that the dapagliflozin has demonstrated that effect across the left ventricular function. And this I leave you with the same slide I left you earlier. So basically, there is a clear indication for the SGLT2 inhibitors. Then whenever we intercept the patients with preserved ejection fraction, with a left ventricular function greater than 40%, then if they are in the range of those patients that have improved, then use the neurohormonal modulation, because that has been shown to be effective, but always treat according to the underlying comorbidities, according to the indications of the Heart Failure Association. Thank you very much.
Thank you very much.